Hey guys, I'm going to be talking about how burns affect patients, classifications of burns, and treatment of burn victims. I chose this topic because I shadowed in a burn unit for 6 months and realized there is a vast number of practitioners who are unaware of how to properly handle burns, so I thought we could all use a little education on it today. So let's start with some general features of the skin, how it is affected by burns, and how patients can get burned. The skin is responsible for thermoregulating, acting as a barrier to foreign objects and pathogens, and fluid maintenance. When the skin suffers the trauma of burns, it loses the ability to adequately maintain these functions. Once the skin is damaged, the body responds by clotting vasculature, increasing inflammatory mediators, and promoting cell death, which all lead to microvascular dysfunction. There are multiple mechanisms that can cause burns. Thermal burns include dry heat, steam, flames, and UV radiation. Chemical burns, such as hydrochloric acid, are also common. It should be noted that alkali burns produce more severe burns. Electrical burns are special because they cause both external and internal injuries to bones and muscles as the current travels. Radiation burns can develop from explosions, but are more commonly associated with cancer patients receiving ionizing radiation therapy. Clinical assessment of burn victims is typically straightforward, as the patient will be able to tell you how the burn occurred. Signs and symptoms of a burn can vary based on the degree of the burn as well as the mechanism of injury. We'll review the different classifications of burns on the next slide. Initial evaluation of a burn victim should include what caused the burn and evaluation of percentage of body surface area involved. Body surface area can be calculated by using the rule of nines shown to the right, or the palm method, which estimates the palm of the patient to be 1% of their total body surface area. Special considerations are taken based on the mechanism of injury. For example, inspection for black soot in the nares and oropharynx should be assessed in all patients with exposure to fires. For those with chemical burns, an EKG and x-rays of surrounding bones should be considered to assess for cardiac dysrhythmias and fractures produced by the traveling current. There are 4 degrees of burns. First-degree burns are confined to the epidermis and present only with pain and redness. Second-degree burns are separated into superficial and deep. Superficial second-degree burns are confined to the superficial layer of the dermis and will present with blisters and skin that blanches with pressure. Once the burn reaches the deep layer of the dermis, you can see color variation from red to white skin that does not blanch with pressure. Third-degree burns go past the dermal layer into the subcutaneous fat. These will appear as leathery, charred skin without blisters. A big sign that the burn has passed the dermal layer is the cessation of pain, as the nerve endings reside in the dermal layer. Fourth-degree burns reach the muscle or bone and will be evident as they will be exposed. Understanding the severity of burns is important for determining the treatment. Minor burns are classified as first-degree burns, second-degree burns less than 15% total body surface area, and third-degree burns less than 2% total body surface area. Moderate burns are second-degree burns covering 15 to 30% of TBSA, and third-degree burns covering less than 10%. Critical burns are second-degree burns over 30% and third-degree burns over 10%, including burns to the face, hands, or feet. During the treatment of burns, stabilization of the patient should be at the forefront of treatment. Those presenting with smoke inhalation should undergo preventative intubation, replace fluids as needed for those unable to maintain appropriate blood pressure using Parkland's formula. Contaminated burns should also receive a tetanus shot. Minor burn patients can be treated in the outpatient setting with the main focus of infection control. Early debridement and grafting are considered the gold standard for deep second-degree and third-degree burns. Moderate burns and critical burns require systemic management. Fluid replacement using IV isotonic crystalloid solution should be initiated on adults with burns covering 15% or more total body surface area and children with at least 10% TBSA affected to prevent hypovolemic shock. Early involvement of a dietitian is crucial to ensure that nutrient demands are being met. I've also listed some topical agents that can be used for second and third degree burns. Knowing when to refer is important as a clinician. Referral to a burn center is imperative in patients with critical burns. Any problematic burns, such as those involving damaged airways, extensive soft tissue injury, fractures, or electrical burns, should also be referred. Patients requiring intubation should be referred to the intensive care unit if the burn unit is not properly equipped, and patients with moderate burns need to be admitted to the floor. It's also important to note the complications that can occur after a significant burn. Hypovolemic shock is the most life-threatening complication of major burns. Acute kidney injury is more likely to occur if proper fluid resuscitation is not initiated. Damage of the skin can also lead to sepsis and the formation of compartment syndrome. Patients with inhalation injury are likely to experience upper airway obstructions, pulmonary infection, bronchospasms, and respiratory failure as complications. Burn injuries acquired from high voltage electricity can cause cardiac damage, dysrhythmias, and fractures. These are just a few of the most common complications. For a more thorough and detailed look at burn complications, please feel free to pause and review the flowchart listed. Thank you so much for sticking around. These are my references if you'd like to go deeper into any of the topics that we have discussed. Otherwise, I hope you all have a wonderful week. Goodbye.